Hi, this is Brian Kim. I want to share with you this case of a patient who came in with a dislocated IOL. This is an Allergan SI30 IOL, and you'll be able to see that because the optic haptic junction has these rings made of that polypropylene haptic. And so what I've learned with this technique is you can actually refixate this lens even though it's been sitting in the eye for almost 30 years. And so this patient has dislocated lens. The SI30 IOL with polypropylene haptics actually are very strong. They felt similar to the polyvinylidene fluoride haptics of the C2 Lucia lens. And so they were quite robust. And this is an older case, and you're going to see I'm going to actually externalize the leading haptic with forceps instead of using the 25 gauge docking needle technique, which is what I use now. But again, because the haptics are robust, I was able to cannulate these haptics through a 30 gauge thin wall needle and executing my modification of the Amani technique using the trailing haptic first technique. So you can see this is the eye, and unfortunately you do not see the IOL. It's back there though, I promise you that. So we're going to go ahead and make our incisions here, and these incisions are going to help us retrieve that lens which is floating tenuously in the vitreous space. And so remember, when you're making incisions, you want to be strategic with your position of the incisions when you're going to do this technique. I like to sit supratemporal, so this looks like this is the right eye. Intracameral epinephrine and lidocaine. I'm using the Maltzman to retract the pupillary edge, and you saw there's some remnants of capsule, but also you can see the lens is dangling right there. Thankfully, it's not falling, it's just sitting there. And so now I'm going to retract through the left paracentesis with the Maltzman, and then grabbing the haptic with the microforceps. And now I have two paracentesis incisions. I have to figure out what I'm going to do next. I switch hands in the left hand with microforceps, grab it with the left hand, handshake it, and then I have the haptic. The trailing haptic is now popped into the anterior chamber. Now that it's in a more stable situation, I'm going to go ahead and place the trocar. I'm indenting about 3.5 to 4 millimeters back. I'm going to tunnel with the trocar needle, tunnel a couple of millimeters, and then I turn perpendicular, and then I dive down. And you can see with the trocar sitting sideways, that's an excellent beveled incision, which should self-seal. I'm going to now place a 3 millimeter supratemporal keratoma incision with the diamond blade, and then using microforceps, very carefully, gently try to pull out this trailing haptic. You can see, again, it bent a little bit, but as you can tell, pretty robust in its tactile sensation and appearance, similar to the polyvinylidene fluoride haptics, in my opinion. Go ahead and make my contralateral limbal incision, which is going to be used for the trailing haptic first technique, using microforceps to hold the lens in the left hand, and then I'm sweeping the iris so that the leading haptic comes out above iris plane. Now I'm going to use microforceps to grasp the haptic through that contralateral limbal incision and perform a handshake technique, grasping it with the right hand with the haptic, and then grasping the tip of the haptic with the microforceps and pulling it out through that contralateral limbal incision. By doing it this way, this fixates the lens in a good and stable position. I push some viscoelastic in to push the optic away from the corneal endothelium. I make a limbal mark, and then I use a cannula to mark 2.5 millimeters back and then 2 millimeters adjacent. I use a cannula to find 180 degrees apart, and then I mark 180 degrees apart on the limbus, and then using calipers and to mark 2.5 millimeters back and then 2 millimeters adjacent. This is obviously an older case. I now use that fixed caliper that I got through Epsilon. I go ahead and place my 20 gauge AC maintainer, and then I begin my anterior vitrectomy. And with the anterior vitrectomy, you want to be very thorough, especially in the area where you're going to be placing the needles. And so on the left side and right side here, I'm going to make sure I do a good vitrectomy. I see some strands coming through the paracentesis incisions here, and so I'm sweeping with the cannula very gently and then making sure I eat the vitreous with the vitrector. As you can see, the vitrector is coming through the pars plana. I'm getting underneath the optic and making sure I get close to the incisions, again above iris plane, to make sure I get that vitreous. And sometimes you have to switch back and actually go from an anterior approach as well. You just want to be thorough, making sure you get all of it out. After I feel pretty good, you can see I'm going to 6x speed. Again, the point is thorough anterior vitrectomy. And so I've noticed this when I teach the wet lab, people get confused with the placement and bending of the needle. And so first you want to, this is the right side needle, I'm bending it about 9 millimeters back. You can see that the bevel is facing to the right, but when I'm actually going to position it to cannulate the trailing haptic, you want the haptic facing toward me. And so it's facing the left here, but if I rotate it 90 degrees clockwise, it would be facing toward me. And so the point is you hold the needle in that position, and then you turn the syringe up towards the sky. You want to point it upward, and then you're bending it about 80 degrees. And by doing it that way, you have very good control, and you're correctly positioning the bevel of the needle the same way every time. I've noticed that when my students, when they're bending their needles, they're not quite sure how to bend the needle, and that's really how you do it. You first position the needle the way you want to, and then you grab it with hemostats, and then you bend the syringe upward towards you. So same here, bending it at the hub right there, having the bevel facing away. So again, this is more appropriately positioned because this is going to be the left side needle for the leading haptic. You see that the bevel is facing away, which is what you want. I'm bending the needle with the hemostats, and then I'm turning the syringe, the handle, the hub of the needle upward towards the sky. And by doing it this way, this is going to simulate how I'm going to hold the actual syringe, because I'm holding it like a pencil. The syringe is somewhat vertical, and therefore the needle has to be fairly perpendicular. And by bending it like this, and you have very good control of how you're positioning that bevel. If you don't have a good position of the bevel, it's very, very hard to cannulate that haptic through the needle. And again, this is one of those things that once you do it more and more, you really get a better idea of what that means. So I'm going to hold the trocar with forceps in the left side, holding the eye in the neutral position. With the left side needle, I'm tunneling 2 millimeters, and then I'm diving in. And then I rotate the needle into view here. And this is very, very important. When you grasp that haptic, you want to make sure you grasp it vertically. Grasp it vertically, because then you're not turning it up and down. And then you're going to make sure you dock the haptic on the bevel of the needle, flatten it out, and then you cannulate it. So again, dock it, flatten it, and now it goes very nicely and easily cannulating that needle. Again, this is a polypropylene SI30 IOL haptic, which has been in the eye over 25 years. Very strong still, very good lens. No reason to throw the baby out with the bathwater. Keep that lens if it's in good condition. So go ahead and use hemostats to hold the needle hub in the neutral position without moving, and then I twist the syringe off. Let the needle lie down. Internalize the leading haptic with microforceps, using forceps now to grasp the incision. Holding the eye in the neutral position, I have the needle at that first mark. I'm going to tunnel again about 10-15 degrees. But you see what I did there? I hesitated, and now there's heme. And so that's another key with this technique. You can't hesitate. You have to, like a golf swing, you have to be confident, and you need to go for it. If you hesitate, if you stop, then it's going to be hemorrhages. You're going to lose your orientation. Luckily, this still went well. I was able to tunnel 2 millimeters and dive down. And now I'm going to, and you can see that bevel is facing away from me. I'm grasping the haptic, but you can see it's kind of bent. But I'm going to dock the haptic on the bevel of the needle, flatten it out. And you can see when you flatten it out, now it goes in really, really nicely. Go ahead and pull the left side needle towards me, because that's the direction in which it came. As I pull it towards me, the haptic comes out. I grasp it with microforceps so it doesn't slip. Then I cauterize the tip. You can see it creates a beautiful small bulb there. Same thing here. I'm going to pull the right side needle away from me because that's the direction it came from. And as it comes out, I'm making sure that I grasp the haptic so it doesn't slip with the microforceps in my left hand. So it came out really nicely there again. And then using cautery to create a small bulb. Beautiful. So again, really, really nice. The bulb is really small. The haptics are really robust. So anyone who has an SI30 lens that's dislocated, just know that you can refixate it with the Yamane technique. And we did publish this as a case report in the Journal of Cataract Refractive Surgery. And so you go ahead and push the bulb flush to the sclera, and then you want to make sure that the conjunctiva is reapproximated. You can see I'm using forceps to hold the trocar so I have better exposure, so I can push that haptic flush to the sclera. And then again, you want to make sure you reapproximate the conjunctiva. I'm injecting some intracameral cannulog now just to make sure there's no vitreous. I think there's a little bit of vitreous. Maybe it's tethered to that contralateral limbal incision. So I'm going to go in and make sure I do a good vitrectomy in that area. You see it's a little bit peaked right there. I think I got it right there with that sweep. So you're doing good anterior vitrectomy. You can see there's some heme coming, and it's actually coming from that left side. So I wonder, because you see I have a little bit of subconjunctival hemorrhage there, somehow is that seeping into the sclerotomy, or is that just bleeding from the ciliary body? It's really hard to tell. But the point is, anytime you hesitate like that, you can get more hemorrhage, and it's important to be confident when you make those maneuvers with the needle. I think that's another very important point. The more you go in and out and in and out, and you're not confident with the needle placement, you can have more hemorrhage and potentially more complications. Of course, you know, hemorrhage is not that big of a deal, but it's going to make the visual recovery be longer, because if there's vitreous hemorrhage and so forth, the patient won't see very well after the surgery. So again, you're doing vitrectomy from the pars plana, but also from a limbal approach. You're just making sure that there's no vitreous in the anterior chamber, checking all the incisions, make sure they're free of any vitreous. And then again, in a lot of these cases, it's not like there's huge gelatinous boluses of vitreous in my experience. When the lens dislocates, that's because the vitreous is also liquefied. And so thankfully, you're able to reposition these lenses pretty confidently without worrying about getting too entangled with vitreous. This is the vitrector-assisted PI. I switched the setting. You can see the cut rate is at 30 fixed. And I'm going through the limbal incision superiorly, and I'm going and making the PI temporally here. It's very controlled. It's a very small size. It's far peripheral, and you're able to perform a very well-controlled and sized peripheral iridectomy with this technique. Do some more anterior vitrectomy while I'm there. Going to go ahead and hydrate my incisions now. You can see that the lens is perfectly centered. I always place a tenonylon suture at the end of these cases, because no matter how good you are, there's always potential for oozing of fluid out of the eye, and I don't want any vitreous at my main wound especially. So place that suture, tie it off, pulling the trocar out, massaging the eye. You want to activate infusion when you pull that trocar out, because that increased infusion will help tamponade the sclerotomy as well. You can see there's no fluid coming out of the sclerotomy, so that's a good self-sealing incision. Take the trocar out, hydrate the incisions, and then inject some intracameral lidocaine and antibiotics at the end of the case, as well as subconj cannulog. And so you can see this is a dislocated lens, 25 plus years dislocated, tenuously held within the capsular bag somehow, was able to perform my modified Yamane technique, externalizing the leading haptic, and then performing trailing haptic first by cannulating the right side needle first. The SI30 IOL has strong polypropylene haptics. These are very, very sturdy. Again, you saw the haptic optic junction has these little circles on it. That's the characteristic sign that this is an SI30 lens. These lenses are excellent to perform the Yamane technique. The curvature and design of the haptics is actually quite ideal, very similar to CT Lucia as well as the Sensor lenses, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.